So hopefully this is where you're expecting to be. So this is our fourth webinar in the DeNPRU Exeter webinar series, and we're delighted to have you with us today. So this comes to you from DeNPRU Exeter, which is a policy research unit in dementia and neurodegeneration, one of two focusing on this very, very important area. And while Exeter is in the title, we actually have partners and researchers based around the country, and indeed out of the country, as you will notice in Ulster and Sydney. So we are more sort of geographically expansive than it might first seem. And I always say we're possibly nearer to you than you think, if you're imagining that, oh, well, Exeter's quite far away. And this today's webinar comes to us largely from the team based at University of Bradford, who we're going to hear from momentarily. So what is a policy research unit? It's a very good question. So rather than primary research, we conduct policy research, and PRUs are composed of experts and researchers who undertake policy research to provide evidence to support national policy making. So really what we do is feed directly back to Department of Health and Social Care and also respond to their policy needs as they tell us what they would like us to look at. Okay, so it's a very direct relationship with DHSC. Having said that, it's important to note that the views expressed here are those of the authors and not necessarily those of either NIHR, our funder, or the Department of Health and Social Care. What are we in for today? Well, I'm about to pass over to Professor Jan Oyebode, Deputy Director of DeNPRU Exeter, who is going to talk us through some of the findings from this ongoing policy research project around inequalities. And then we're going to hear Maria and Shafaq in conversation, again around the project, but also around Shafaq's own experiences as an expert by experience. And then we will open the floor to audience Q&A. All right, so that's what we're in for. And of course, if you wish to find out more about DeNPRU Exeter, we are ever so available on the internet, as one always is. And at this point, I'm going to stop sharing and invite Jan to share her presentation, please.
Thanks very much, Kathy. And thanks to everyone for coming today to this webinar to hear about our work and join discussion of what is, I think, a very important topic. On this slide, you can see the full title of this DeNPRU Exeter project, which is about reducing inequalities across the care pathway for people from minority ethnic communities who are living with neurodegenerative conditions. I'm not going to talk for long, but I want to give you the headlines of our findings from the first part of our work in the project. And I'd like to begin, except my slides don't want to move, by acknowledging some key people. So I'm here presenting to you today. I'm Deputy Director of the Policy Research Unit, and I'm a Professor of Dementia Care at Bradford's Centre for Applied Dementia Studies. But actually, I'm not in the lead of this project. My colleague Sadia Parveen is the person who proposed this project area and was involved with the start of the project and then has taken maternity leave, from which she's recently returned, and she is here today. So you may hear from Sadia later when we get to discussion. And in the middle picture, you have Maria, who's already been mentioned by Kathy. Maria's a research fellow with us, and she's done all the hard work that forms the basis of this project. And Kathy, who you've met, I wanted to acknowledge too, because a really key part of our work is about engaging with stakeholders, making sure we have the voice of people with lived experience and that we're able to consult as we go along with our projects. And without Kathy's help, we wouldn't have been able to do the consultation work we've done, nor indeed would we have such a beautifully organised webinar as we have today. So I'm going to briefly set the context by talking about, first of all, the numbers of people from minority ethnic communities living with neurodegenerative conditions, and then saying something about the different steps of the care pathway. So in the UK, we estimate that about 60,000 people from minority ethnic backgrounds live with one of the 4 most common neurodegenerative conditions. And you can see some figures here. And there are a large number of other rarer neurodegenerative conditions too. But this number means that probably at least 250,000 people are pretty directly affected when you think of these individuals and those close to them. And numbers will be set to continue to increase over time as people who've immigrated to the UK age. So this is a very important section of our society. And we know that being from a minority ethnic group is associated with inequalities and inequities in dementia care. There's not so much evidence about the impact of ethnicity on help-seeking assessment, diagnosis and access to services for the other neurodegenerative groups, but it's very likely that the same pattern of inequality and inequity holds because of broader issues in society. And we've thought about this in relation to the care pathway, that the evidence would suggest that inequality and inequity begins right at the beginning with when people come forward to seek help and whether they come forward to seek help. And then it moves on to the process of assessment and diagnosis, because people, there may not be assessment tools that are always entirely suitable for people who aren't from the background, samples, populations on which the assessment tools were based, and people may have less good assessment and they may be delayed in getting a diagnosis. And there are often a number of barriers to accessing treatment and support. So we're carrying out work in this project that goes across these areas. And today we're going to talk really about our work on help seeking. We focused on stigma and lack of awareness because these can make it much harder for people to ask for help. If you feel awkward about possibly finding out and then having to reveal to others that you have a diagnosis that carries stigma, you're probably tempted to hide it away rather than to find it easy to approach people to ask for assessment and help. And in non-white British communities, in minority ethnic communities, the perceptions of neurodegenerative conditions are often different from those in the white British. So, for example, thinking about dementia in particular, in South Asian communities, mild dementia might be seen as normal aging, and you wouldn't go and seek help for normal aging. And if you have severe cognitive impairment and severe symptoms of dementia, this may be seen as madness, which carries a lot of stigma. And people may see symptoms as punishment from God, which may take you in the direction of asking a religious leader for assistance rather than asking health and social care for assistance. And in Black communities, we hear quite often that dementia may be seen as a white person's disease, not something to concern you if you're not white. As mentioned, there's less research with the other groups, but Parkinson's disease, we know, also has been found to carry some culturally based stigma, and there's not so much research in MND or Huntington's. But bearing this background in mind, what did we do? We decided that we would focus on the South Asian and Black communities because these are currently 2 of the largest minority ethnic populations in the UK, and they are populations that have now an ageing demographic profile. So we need to know how to support people from these communities because many of these conditions are likely to develop in middle age or later life. So we decided that we would look for examples of campaigns. We looked both within the UK and internationally. We looked for campaigns that were aimed at raising awareness or reducing stigma around neurodegenerative conditions for minority ethnic communities. And what we wanted to do was understand the characteristics of these campaigns when we look at them together. What are they like? What sort of cultural adaptations or cultural angles are included in these campaigns to appeal to the communities that they're addressing? And what do we know about how effective they are? So we searched 3 academic databases and 77 websites, and we conducted a broader internet search using Google to identify the campaigns. And we counted a campaign as anything designed to promote awareness or understanding of a neurological condition. And you'll see when we come to our findings how varied the campaigns are. And having looked at these and had a look at their content and their format, we also consulted people from minority ethnic backgrounds who were living with or caring for someone with one of the neurodegenerative conditions. And we consulted providers from charitable and statutory services about their views on campaigns too. So hopefully the interesting bit is what we found. And we identified 34 campaigns. You can see on this table, on this bar chart, the numbers of campaigns with dementia, Parkinson's disease, Huntington's disease, and motor neuron disease. You can see very easily that there are most with dementia, quite a few with Parkinson's disease, and very few with the other areas. And the light orangey colour, the yellowy colour, shows the web sources, the campaigns we found by our internet searches, and the orange shows the academic papers. So you can see that there are very few academic papers. There's been little research evaluating the impact of the campaigns, even though there are a reasonable number of campaigns out there. When you look at the ethnic communities targeted in the campaigns, you can see here a column for campaigns targeting Black populations and a column for campaigns targeting South Asian populations. And you can see that there are campaigns across both. But one thing that we thought was quite significant was that when you look at the evaluations, there are only 5 papers that we located with Black populations. And of these 5, 4 were conducted in America with African Americans, and the cultural context, of course, is very different. So it may be that we, from this information, we can talk about the characteristics and the cultural adaptations, but we can say less about how effective the campaigns are, because particularly with Black populations in the UK, we have very little evaluative information. So that's numbers. So what was in these campaigns? The formats of the campaigns varied really widely. You can see the main categories here, and that by far the most common were videos, and there were also a number of podcasts, but there were leaflets, community initiatives, webinars, a couple of less usual things, people developing a song together, for example. We won't do that today as a group exercise, but it could be interesting, couldn't it? But, you know, some really imaginative ways that people had tried to campaign to bring to the attention of their community the nature of these neurodegenerative diseases. So after looking at format, we also looked at the content and how that content was conveyed to the target group. And I think this is quite important, because if you were designing a campaign, there is something we can learn here about the most common ingredients. So the campaign content covered some of the things you might expect in terms of information about a condition. So it often covered perceptions of a condition, how to recognise the early symptoms and where to go to seek help. The campaigns often covered the process of diagnosis and talked about the importance of early diagnosis as a gateway to support rather than leaving things later. It talked about planning care, and quite a lot of campaigns talked about what treatment, care and support services were available. And in our later consultations, those we consulted felt it very important not only to have information about the medical nature of a condition and its symptoms, but also to have information about where to go for help and care. And the campaigns also covered some issues that we might regard as particular to different communities. So some campaigns addressed issues of stigma head on, or they picked up possible issues around stigma and awareness, how to tell others around you if you have a diagnosis, how you might deal with any family tensions that arise because of different reactions to that diagnosis. And some campaigns talked about faith and spiritual influences on health and healing, recognising the importance of faith in many minority ethnic communities, which is probably not as common in what has become quite a secular mainstream society in the UK. So that was the content. And how was this information put across? So some aspects of conveying information were quite common ingredients across these campaigns. Many campaigns used personal stories, and again, our consultees later confirmed that they felt personal stories were a really effective way of conveying information about health conditions. And these personal stories might be put across by real people living with conditions, or by actors, and they were often complemented by insights from professionals. There were also conversations between those affected and professionals. This was quite commonly used, and it was often conveyed in a fairly relaxed fashion. So not a formal talking head of a person in a white coat with a stethoscope telling you about the health condition, but a more natural conversation between someone asking about their health condition and a professional who had some specialist knowledge to use in their answers. A lot of campaigns used creative, engaging materials or activities, quizzes, culturally relevant images, and so on. Presenters were sometimes from the relevant ethnic groups, and where needed, some of the campaigns used community languages, and we found some resources that were available in a wide range of languages for different groups of people that we find within the UK population. So what about the evaluation of these campaigns? Is it helpful to put your efforts into campaigning for a particular target ethnic group to hear more about a neurodegenerative condition? What difference does it make? So we only located 8 studies in this area, but I think it's fair to say that the evidence to date is quite promising. So a range of interventions were found to be acceptable to people. These included face-to-face seminars, leaflets and videos. All of these were acceptable. The campaigns were also found to have a positive impact on knowledge. There was maybe a hint that the impact on knowledge is particularly good when there is either an interactive component. So, for example, one study had a presentation about the neurodegenerative condition, which was followed by discussion in the group, enabling people to check their understanding and ask questions. And another intervention was the information that was given in a leaflet was followed up with culturally tailored text messages. So again, something personal to people. And there was also some evidence that the interventions do impact positively on help seeking, that people may be more likely to come forward and go and approach their GP if they have worries about memory problems that they think might be due to dementia after taking part in or being the recipient of a campaign. There are also possible differences between communities, which I think isn't surprising at all. You know, we can't really talk about the Black community or the South Asian community because there are many different communities, and this, you know, filters right down to an individual and family level and a local level, as well as taking into account the bigger issues of different values and beliefs in broader communities. So that's the information that we gleaned from locating the campaigns. And what did we learn from our consultations? I've mentioned this a little bit as some of these themes as we've gone along, but the discussions were very valuable, and there were some particular themes that came out from these. One was that campaigns should go across generations. We shouldn't only be targeting middle-aged and older generations who might be most at risk of developing a neurodegenerative condition. We should also take campaigns to people of school age who may carry messages through to their family, and maybe starting without many preconceptions. So campaigns should go across generations. There was a view that we need multiple formats. There isn't one format that's going to be suitable. Even though videos seem particularly popular, we need multiple formats to suit different individual preferences and generations. And I liked this quotation about my parents are in their late 70s. Parkinson's and dementia are words they know. It comes from the TV channels that they watch. They're a brilliant medium of getting into people's living rooms. So we know, you know, that the soaps carry a lot of messages through to communities. We also heard a lot about the need to build trusting, sustainable relationships, and where people gave examples of long-standing relationships, they felt they'd been able to build bridges between a community and health and social care providers that paid dividends. And there is an issue that a lot of funding for initiatives around raising awareness in different communities is time limited, and this can mean that you start to build up a relationship and then that's lost. People stress the value of campaigns being in person and focused on conversation and stories, and people appreciated it when the messages were delivered by someone with shared ethnicity or a health professional who carried credibility in the field. But people also value social media and community TV and radio, as well as face-to-face campaigns. Because of the stigma, head-on campaigns on neurodegenerative conditions might work best when embedded into broader initiatives. And we had one example here where a participant in one of our consultations said you could have some kind of mobile unit, such as a bus, which is about Black health, with someone there who would talk about various things affecting the Black community. And people might approach that because it's about health in general, and they could find out about neurodegenerative conditions as part of that broader initiative. People talked about the need for having a wider workforce that's culturally competent, as well as having dedicated community engagement staff. And I suppose we've become used to the idea that most staff have some training in cultural competence, but we had a lot of examples of cultural incompetence. And when we consulted with people from charities and other organisations, people sometimes weren't sure where to access the best training. And quite a lot of the charitable bodies might have a volunteer workforce who might not be very familiar with people from different sections of society, and might need to start to learn how to feel comfortable and how to talk about issues with people of different ethnicities. There were also gaps in data on ethnicity. And as someone said here, how on earth can we see if we're reaching diverse communities if we don't know who's in that community? So, as Kathy said, we're a policy research unit, and having drawn together this information, we wanted to think about the policy implications and recommendations. We have drawn out 5 particular themes that we think come quite strongly from this, and we have had a think about the implications of these 5 areas for policy. So we need tailored campaigns that are for the general population, may not hit the spot if you are from a particular minority ethnic community and you don't see images of yourself in the campaign, or the campaign doesn't seem to take into account your values about delivery of care. So campaigns need to incorporate culturally tailored messages and culturally tailored modes of delivery. And it may be that we need to embed these campaigns in wider initiatives to get round stigma and work closely with existing community groups. So then we felt a second theme was around the workforce. People clearly appreciate it when someone who they can identify with is the person presenting information in campaigns. And we know that health and social care sectors have a very diverse staff, but we need to continue to make sure we attract staff from diverse communities who are among the professionally qualified people in health and social care. And then we need to ensure that all staff, whatever their ethnicity and background, have cultural competence and confidence. This plays a little bit into our third area about ethnicity data. People talked a lot about needing the data, particularly the organisations that want to make sure they're providing for the community they serve, but they don't know how to find out who they should be serving. And data on ethnicity are supposed to be collected in organisations, but the data are often incomplete. And sometimes people feel awkward to ask. So there's an interplay here between cultural competence and ensuring ethnicity data. But we also need systems that will capture these. And so this is key. And then we have a theme around sustainability. As we've heard, long-term relationships are really vital to build trust, particularly if you're from a community where you feel marginalised and you know that you have inequitable services. It needs someone to be proactive and reach out to you and offer to work with you. We can't in services sit and expect people to come to us. So long-term relationships are vital for this, and it links in with the nature of funding and how can we get longer-term plans that will make sure that our initiatives and campaigns are sustainable. And then finally, collaboration. We clearly need to share resources across services. We don't need to always reinvent the wheel. There may be something there that does what we need. But if we don't share resources and collaborate, we don't know about it. Some of the best resources might be produced by small organisations that are very aware of the needs of their community, but they may not have the resources to raise the profile of what they produce. So joint initiatives can help with this. So I want to finish just by saying a little more about some of those recommendations. For tailored messages, we talked about the content earlier, and I think part of the tailoring means working with communities to think about what are the culturally based barriers that might prevent people from seeking help. And how can we include messages about those barriers in campaigns? These might be things, for example, in the dementia field, like stressing that dementia is a physical illness, acknowledging values around family care, and maybe around gendered care, and addressing concerns about confidentiality and about autonomy. To have a culturally competent workforce, we need to spread this knowledge of available resources. One of our participants said that the Royal College of Psychiatrists have materials around minority ethnic groups and dementia, which are free to access. But of course, other people didn't necessarily know about these. And we know from Bradford that e-learning for healthcare has an online module that's relevant to this as part of its dementia suite of modules. But clearly not everyone might know about that. So we need a good way of sharing the resources about developing a culturally competent workforce. In terms of strengthening collaboration, the integrated care boards and integrated care systems ought to be able to provide a way of networking that will link statutory services and community organisations. I've just put in an example here from some years back of the Alzheimer's Society Information Programme for South Asian Families as an example of a programme that did involve collaboration. Now, the programme didn't run for long, and even though evaluation showed it probably had positive impact, it was in some ways an example of a short-lived programme. And there was some criticism of the collaboration. But on the other hand, the Alzheimer's Society did reach out to local Black and minority ethnic organisations in order to co-develop materials that covered particular issues and in order to co-organise the sessions in which the programme was delivered. And we do have evaluations of that. For ethnicity data and sustainability, we don't really have many examples to give, but if it's possible to share ethnicity data regarding local populations with partner organisations, this could make a big difference to people understanding how their population profiles are changing and making sure that they're providing for their local populations. And as mentioned, we really need longer term strategy. So there is much more detail of our findings in our full report. We've had the go-ahead from NIHR to publish this report. So if it's not already on our website, it will be there probably within the next week. And you can see much more detail within that. We're now working on work streams 2 and 3 on assessment and diagnosis and on barriers and facilitators to accessing treatment and services. So we'll equally be producing findings from these 2 work streams over the coming months. And if you'd like to be in touch, we're very open to discussion. We're keen to have feedback. The whole point of us being in DeNPRU Exeter is to try and get change for the positive. So please don't hesitate to get in touch with Maria or Sadia or myself or with DeNPRU Exeter via the email address that Kathy shared and is on here. And thank you very much for listening. Before we open up for discussion, we're going to hear from Shafaq in conversation with Maria. So I can stop sharing my screen and can hand over now to Maria and Shafaq.
Thank you very much, Jen, for the wonderful presentation. So I'm delighted to welcome Shafaq. And Shafaq is one of our 2 experts by experience who has been supporting the project and been working with us since the very beginning. So Shafaq, over the next sort of 10 minutes approximately, we thought this would be a nice opportunity to hear directly from you about your experiences from first noticing your symptoms to getting a diagnosis at a relatively young age. So I will hand over to you to tell us a little bit about you and the condition that you're living with. And then I've just noted some questions that we can sort of work through together. So please, let's welcome, and be wonderful to hear a bit about you.
Okay, so thank you. My name's Shafaq, as you already know. I'm currently 46 years old, and I have a condition called early onset Parkinson's. I was diagnosed when I was 40 years old, but had symptoms from about, I'd say 31, 32, basically not long after I had my second child. And my very first symptoms presented as me falling over and recurrently falling over, my right ankle giving way. And I work as a dentist, by the way. So I would notice that when I was working in dentistry to press the pedal with my right foot, it would hurt. So those are the very first symptoms I presented with. Gradually, the symptoms built up over the course of like the next 9 years. And eventually, by the time I got to 39, my husband and I sort of already guessed the diagnosis and then presented to a doctor, and I was diagnosed at 40. And that's me in a nutshell, really. I live in Yorkshire and work in Yorkshire as well.
So those 9 years then of the process from first noticing the symptoms, I mean, that was such an early age, and I suppose Parkinson's wasn't on your mind at all as a potential, a potential diagnosis.
No, it wasn't on my mind at all. It's not in my family. No one in my family has ever been diagnosed with Parkinson's. And it was something that, I to be honest, despite being a dentist, I really wasn't aware that younger people get Parkinson's, not as young as in 31, 32. So I didn't even entertain the notion that there was something more widely wrong with me. I thought it was a local problem in my ankle, that my ankle was giving way. I'd fallen over once and my ankle had maybe sustained some ligament damage or something. You explain these things away when they're sporadic and when they're one time my right wrist hurt, and then another time it hurt as well. Or I was a bit cold, so I was shaking quite a bit, but I didn't notice it was just on my right side. Lots of things like that where you just, because the symptoms are disparate, you don't put them together and why would you? Why would you? So yeah, it took a long time for the symptoms to all amass, and it was only when I finally wasn't able to use the mouse at work with my right hand that I realized it could be Parkinson's. To be honest, that's the first moment. That was around October 2018 when I first thought this is Parkinson's.
And when you first had the diagnosis sort of confirmed, I know it was a long sort of drawn out trajectory to get there. You said that it wasn't too surprising to you and your family at the time because you'd sort of done your own research and sort of come to terms with what it could be.
Yeah, okay. Absolutely. My husband and I both guessed that it was Parkinson's, and he's medical as well. Sorry, I should explain. My husband is medical. He's a surgeon. So whereas I'd noticed some things, he'd noticed other things, and putting them together, we were like, it's Parkinson's.
So both from maybe a clinical background, you had a bit of a head start then and sort of noticed, yeah. And I mean, when you, within your sort of local community and your family and friends, I mean, were you quite vocal in sharing about your diagnosis, or did you feel that was any potential for any sort of negative sort of social judgments? Or, I mean, how were you feeling about that process of sharing it at that point?
So initially when I was diagnosed, despite us being aware that it probably was Parkinson's, having it confirmed was still a shock. I'd been hoping I was wrong, but at the same time as it being a shock, it was also a relief that it wasn't something worse. So it wasn't all bad. And it took me, I'd say, about 6 to 12 months to get over that initial hump, the initial diagnosis, getting used to it, telling my family, telling my immediate family, my parents, siblings, and very good friends. And then after about a year, once I was finally used to it, I started working with a charity called Parkinson's UK, and that sort of made me more confident about talking. Actually, I worked in the Race Equality and Research Steering Group, and I saw more Asians with Parkinson's in that, and it made me more confident and made me realize that it's nothing I need to be ashamed of, because in dentistry, so this is a subculture of the work culture within dentists. We're quite proud of our work, and as an Asian, a South Asian, I didn't want people to think there was something wrong with me, because that is what people think, that I mean, obviously there has gone wrong with me, but I didn't want it to be like, you know, suddenly they're feeling sorry for me. I was quite proud like that, and I didn't want people to be talking about me behind my back, you know, gossip. So once I built up my confidence by talking a bit more publicly about my Parkinson's in the research group, I then actually sort of bit the bullet and I announced it on Facebook, so that none of my relatives that I was worried that some of them would be like, oh, she's eating really slow, or she's got a bit of tremor, have you noticed this and that? And I didn't want that. I was like, let me control the narrative. So I put it out there because I thought, so many times we hide these things in our communities. We don't talk about them. It's like it's a secret. It's something's wrong with your brain. They think it's like huge, you know, like what's happened to her, you know. And then it's evil eye and all of this. And I was like, no, I want to do away with that. I want to try and make people from my community feel like they don't have to hide these things. And if I want that, then I have to be the person who leads that way, because, well, otherwise I'll be succumbing to the old norms. So I actually, yeah, just announced it on Facebook and let people find out like that. And but should have seen the dearth of phone calls that came to my mother. It was so many. Yes, there was lots of phone calls Mum got, and then I got, and initially people were scared about talking to me about it because it's still a hush hush. Oh, she's got it type thing. Eventually, they realised I'm not going to fit there. I'm not going to be small enough to fit into their, you know, constructions of what a person with Parkinson's is. I'm gonna, and I talked to them about it, even if it made them awkward. I would talk openly about it.
And I know that you've been involved in some of our previous discussions about the campaigns and the content and the format, and through your own charitable work and as well. I mean, have you noticed more of a openness and, as you said, talking to people and sort of not feeling that you need to hide away or feel any sort of shame? Is that over the years, do you feel that that momentum is gathering for sort of minoritized communities or in your community? Has there been positive strides to address any of those cultural challenges, or how do you feel about where we are at the moment?
I feel that it's, as Jan said, we're not a homogenous community. So I represent, like, I'm from a certain part of the South Asian, the Indian subcontinent. Originally, my parents are, and you know, we're an educated family, and I can only sort of speak for like a few people, sectors of our community. But I would say that within England, the expat, so to say, yes, I think it has become more open. People do feel like they can talk more openly, but not enough, because I still know plenty of people, especially men, who hide, because I think it's that traditional male type, you know, image where they're the providers. And I know lots of men actually who still hide behind the diagnosis, and they don't go out, and they don't actually even, you know, and then there's lots of myths about being scared of taking medication. And so yes, some progress has been made, but I'm really sorry to say that I feel like I need to do more. We need to do more.
Okay, so thank you very much for sharing. That was a very brief gallop through some of your experience. I'm aware we've got just about 10 minutes left, I think, for some questions, either for yourself, Shafaq, or if anyone wants to reflect on the presentation today. So I'll just hand back to Kathy. I don't know if we have a list of questions.
We do have a list of questions.
Okay.
I've been doing my best to copy and paste them as people. They've been coming in the chat thick and fast, and I will save the chat and make sure that that we can respond to things afterwards as well and reflect on them. I don't know if you're seeing the chat, Shafaq, but there's a lot of love for you in the chat, so I would head on over there. Don't miss that.
Thank you.
So first question was a thought and a question on the slide with the 18% estimate of minority ethnicities applied to the estimated prevalence of neurodegenerative conditions. firstly, the percentage of people identifying with minority ethnicity is much lower in the older age group than for the total population. And secondly, have you included white Irish and white other as ethnic minorities? So I don't know
Thank you. Well, yes, it's a fairly crude way of trying to produce a rough estimate of figures in the Huntington's and MND area, where no one has done detailed studies to produce accurate incidence and prevalence figures. Those two conditions do tend to affect people most in middle age, somewhat earlier than dementia. So even though within the older age groups, people, there may still be a demographic where there are fewer old people, but there will be a lot of middle-aged people. And yes, that 18% is a standard figure from census data. So it's a rough estimate really of the possible number of people based on the number with that condition and an overall figure. Good to see you. I think you mentioned something about the Irish population. And I think we needed to focus somewhere in this review, and we didn't look for studies that were particularly related to being of Irish ethnicity. I do think some people of Irish background do feel that they have an identity that is different from mainstream British, that requires some adjustment in the way services are provided that takes that into account. So I do think that some Irish people as a group certainly would say that they are a group who would want their voice to be heard when services are designed to make sure they meet particular requirements or preferences.
Fabulous, thank you, Jan. There was a comment around, I'd like to know what the culturally tailored text messages look like that we'd mentioned in the presentations. And I mean, I can give a bit of an insight into this, because obviously it depends on the organisation and quite who's sending them. I know that in one case, there was a lady from a Somali background who had just sort of started a bit of a grassroots conversation among the elders of her community. And so it was very much around that respectful approach and speaking to people in an appropriate fashion. For another community organisation, it was relaying the same WhatsApp message but in about 13 languages because they knew that the community, that so many different languages were spoken there. And then other people spoke about not just the form of address, but kind of the vocabulary used. So not just that the word dementia might be meaningless, but also using the word carer to try and actually speak and reach out to carers wasn't very helpful when people weren't in fact identifying with the word carer. So trying to give a more descriptive account of, you know, is there a relative or a friend who you're worried about changes in their behaviour and you're maybe supporting them in some way. So those are just some examples I can remember off the top of my head in consultation, but I don't know if anyone else wanted to respond.
I think your response is very helpful, Kathy.
I've just posted in the chat one of the evaluations that actually used, I hope I posted the right title, actually used some text messages after sort of a group discussion, and these they sort of tried to tailor some of the wording in the text messages. So that was working with African American communities in America.
So there is somebody on the call with a research interest in older people in prison, and that in England, about 84% of the prison population identify as white, with 16% identifying as other ethnicities. Given that roughly 8% of prisoners over 50 have mild cognitive impairment or dementia symptoms, which can often be masked by the prison regime, it would be interesting to explore the experiences of ethnic minorities in the prison environment and what campaigns have been used to highlight dementia in this setting. I don't know, did we come across anything that mentioned prisons?
I don't think we did. And I mean, it is a significant issue, isn't it? I remember quite a lot of years ago when I was doing some studying, the emphasis on the ageing of the prison population. And because of the way the justice system works, I can imagine that there might be, a significant group of people where we need to consider those needs. But no, it's very fluently put by the person who's put the comments in the chat. It's a neglected area, I think, probably at the moment.
Yeah, no, really interesting. And what's wonderful about this is that, you're getting us to think about things that haven't necessarily cropped up. So thank you so much. I'm going to try and fit in some more questions. Sorry, I know it's a bit of a rapid fire round, research team. So do we have any reflections on generative AI to support campaigns? Could these tools be used to support personal stories, and would they be acceptable, given the importance of natural conversation? AI can help with representation and language. Anybody have any idea, have any thoughts about use of AI?
As Kathy says, thank you, those angles that we might not think of straight away. And I mean, AI carries its own biases because of the biases that are already there on the internet. So that's an issue too. I think I saw Karen had a hand up.
From the data, what we saw was the reality of those personal conversations which resonated. And anything that is generated takes us at least 1 or 2 generations from those conversations and those intimate conversations that give out those messages. So while it would be interesting to look at, I, particularly given the biases, particularly given the generated avatars, I think there would be some areas to explore.
Thank you, Karen. Sadia.
I think there has been a community group where they used ChatGPT actually to come up with stories to train up healthcare professionals about cultural sensitivity. However, ChatGPT is trained by people to respond in certain ways, and there's a bias in that ChatGPT has been trained by many white global majority people, shall we say. So those cultural nuances that we talk about and the cultural sensitivity wasn't there in the story, so it wasn't actually a very useful tool to use. So with this project, we're very much focused on how can we make the materials that are already used culturally sensitive and culturally specific. And I don't think AI is there yet. That's what I'm trying to say. Yeah.
We're definitely leaving it room to develop, for sure. But yes, I think that the consensus is that we might have a bit of a worry about it right now. Given that it's 3 minutes to 12, and I'm conscious that people might have other things they're dashing off to, I feel that we might have to answer the other questions offline. Please don't worry. I have got them all noted down, and I will ensure that we come back to you on an email basis, because there've been such great questions and comments, and we've been directed to some research around prisons, which is really helpful to help us in thinking about that. We've also had a fantastic conversation around language and the kind of terminology to use, and how helpful ethnicity data might be, particularly given that it can kind of cause further categorizations, and that sometimes when it's not used, they actually have very well functioning healthcare systems. So I will make sure that we, as I say, that we respond to everything in time. And I do apologize that we've run out of time. That's what happens with an interesting topic and very interesting and knowledgeable people in the audience. I do apologize. But if we can just thank all of our speakers, and indeed all of your good selves, for being here and participating so marvelously. This has been a really wonderful webinar, and I do encourage you to kind of stay in touch. You can always join our stakeholder engagement network by dropping us an email. I think probably it's a good time to say have a lovely lunch, have a lovely sunny day if it's warm where you are, and yeah, we thank you so much for your contributions and for coming today.